You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Karan Mohan.
Hello and welcome to another episode of All the Pieces. I'm your host, Dr. Mohan, and today we'll be talking about levels of care. If you're a patient or a caregiver or someone you're visiting, at the time of discharge, you may hear words like skilled nursing facility, LTAC, acute rehab unit, or even a swing bed. To a layperson, these words are just words. But today, to talk more about details, we have some lovely guests with me, and we're very excited to talk about levels of care. And as a courtesy, I always like my guests to introduce themselves. So Denise, we'll start with you.
Yes, I'm Denise Schrader. I'm Vice President here at Mosaic. I've been here about 8 years, and most of my responsibilities lie with post-acute. I do have responsibilities with our hospitalists and our care management in the St. Joe market, where it's very important that we have places to discharge to, and you'll hear more about that and understand about that on the post-acute care side.
Thank you, Denise.
I'm Trisha Anderson. I am the Program Director for the Acute Rehab up on 3 North. So we are a new unit that opened, it was a year in July, and so I've been here just a little bit longer than a year.
Excellent, welcome.
Hi, I'm Dana Anderson, and I'm the president of the LTAC, otherwise known as Long-Term Acute Care Hospital. I've been at Mosaic for 23 years, and the LTAC has been in existence since March of 2009.
Excellent. Lori.
I'm Lori Bishop. I'm the Director of Nursing at our Albany campus of Mosaic. I've been with Mosaic for about 10 years and with Albany for 19. I oversee nursing services, case management, UR, and our swing bed program, which you'll hear more about.
My God, you need more things to do, Lori. So excellent and welcome all. This is something as a hospitalist I deal with on a daily basis of discharging patients. And I know for a fact, a lot of times our patients don't know what exactly that means. There's a myriad of places where they can end up depending on the level of care and the requirements they may have. So you mentioned a word, Denise, and I'm going to switch over to you, post-acute. What does that mean?
Post-acute, if you just look at the words, it's post-acute. Acute means hospital. Somebody's had an acute illness, acute episode that may have brought them to the emergency department. And then it follows up generally to the inpatient, where most of us understand what a hospital stay is. Now, a hospital stay is really where a patient is considered at acute level of care. As Medicare progressed and the payers progressed and technology progressed, we come up with all these additional places that people can have care. We've known probably in our community and healthcare for a long time, we've had nursing homes.
Right.
And we've had a hospital and we've had emergency departments. But because of technology, for example, we have outpatient services now. Many of the procedures, hips, knees, things that we used to do on the inpatient side, which is acute care, is now done on the outpatient side. Right. We have observation. A patient may come to the emergency department and they're sick, but technology and medical services and care has advanced enough that we may get them better in 24 hours. Right. And if they're better in 24 hours, they could go home. So we keep them in an observation status. When I talk about each one of these levels of care, there is also a payer element to those. Right. The payers will pay us depending upon the acuity of the patient, how sick the patient is, and how many resources they have to use. That means physician, such as we identify with the emergency department, the physician is there like a ratio of 1 to 2 or 1 to 1. Right. In the acute care setting, our hospitals have a ratio of about 1 to 15 patients. And in our long-term care, that may be 1 physician to the building.
Wow.
In home health, which we haven't gotten to yet, but home health, there isn't really physician coverage. We have a primary care physician who's in his clinic helping us manage or supervise the plan of care for the home health patient.
Wow, so there's a lot of services, it seems like. So for a patient, they may just be in the hospital, but on the back end of it, there's a lot of different places they can end up. So that's a very good point, observation and inpatient, these things. Do all observation patients qualify for services as well?
No. Observation patients is a category, again, where patient may have an acute illness, but rapidly recovers and then is discharged. They may get discharged to what we call a post-acute care setting called a swing bed, which Lori will talk to more, or a skilled nursing. But depending upon the payer, they may not qualify, and that is what has become much more complex in our world. I've been in care management and the post-acute care world for 35 years, and with each year becomes a difference in who qualifies and what the payer will pay for. So we'll get into conversations, and Doctor, you've experienced that as a hospitalist.
I do. Unfortunately, patient walks in and the first thing you're thinking is where they're going to go once they're all healed up. And that's usually the biggest challenge outside of the medical care. But that's a word you mentioned, swing bed, and I think that's in Lori's shop a little bit.
Yes, it is. Swing beds are super important. It's really that transitional bed where a patient moves from that acute phase of illness to a post-acute phase. They may need a little extra help, a skilled nursing service. Things that come to mind would be like IV therapy or wound care or medication management. Also, physical therapy, occupational therapy, speech therapy. And that's kind of what we specialize in. We're there to help them move from that acute to a safe and successful discharge plan. These are patients that don't meet everything to go home. They need just a little more help, or they need a boost, or they need to be medically stabilized, but they're not in that acute phase of illness. And they get to stay in the hospital, have the lower nurse-to-patient ratio, that sort of thing. So swing bed is great.
It's a great stepwise going back to home. So what's the average length of stay for a patient in a swing bed setting?
Well, it really depends. Different programs offer different, limits on that. Patients can stay on Medicare up to 100 days if it's medically necessary. But also we see patients that are just there for a short stay, 7 days, 8 days, just depending on what their need is. That's something that is very dependent on the patient.
Right, so just to round out the care, like they're done with the active part of the medical management, now it's just
Correct. And what do they need? And we'll work with them, develop that individualized plan of care, and really focus on that.
So how is that different from a long-term acute care hospital?
Yep. So moving into long-term acute care hospitals, so we actually send patients to Lori in swing bed. We actually send patients to Trisha in the acute rehab unit. So LTAC is really the second kind of level of care here at Mosaic. So we have the short-term acute care hospital that Denise and you work in regularly. Next up is really LTAC. So patient still needs hospital level of care, but for a longer period of time. So usually people hear the word long-term, they think nursing home.
Right.
So we're still an acute care hospital. That's the last part of the name. So long-term acute care hospital. Our average length of stay is around a month. So between 21 and 25 days typically. Some stay a little bit shorter, some stay a little bit longer. Denise mentioned payer. A lot of that is payer driven as well. So how long a patient should stay can be dependent on that as well. Many of our services that we provide are kind of in alignment with what swing bed is able to provide. So some of those specialized services, therapies, IV nutrition, new tube feedings, new tracheostomies, and we even do ventilator weaning. So high acuity level of patients that need to be in a hospital level of care, but for a longer period of time.
That makes sense. So these are individuals for a month or longer?
Yes.
What's the longest patient you've had in LTAC?
Actually, I kind of hate to even say it. We actually have a patient here that has been in our facility for 2 years.
My God.
That is payer driven. There is no place with her acuity for her to discharge safely in our region. And actually we've tried in about 18 different states for this patient to have a discharge location. So we are not designed to be a facility for patients to live in, like a residential or intermediate care facility. We're truly an acute care hospital. But as Lori talked about and as Denise talked about, we have to provide a safe discharge plan for our patients. So right now we're the safest place for her to continue to receive her care. But 4 to 6 weeks is kind of our average. Patients that need IV antibiotics for 4 to 6 weeks for whatever infectious process they have. And then coupled with our other population is our complex wound care. So a lot of complex wound care patients, diabetic foot ulcers, diabetic ulcers of any kind, different types of wounds. Hyperbaric oxygen therapy is another thing we provide. That's typically an 8-week treatment. So a little bit longer for that population as well.
That makes sense because they need doctors every day.
Yes.
As always, but they're going to be a longer stay.
Yes.
So these are the kind of the availabilities we have: swing bed versus LTAC versus skilled nursing facility, which I think a lot of people know intrinsically as nursing homes, and it's true for and a lot of patients don't want that. Where does acute rehab unit fit in, Tricia?
Yeah, we take similar patients to what swing bed would take. Our niche is more of that neurological population, strokes, Parkinson's. We focus on 3 hours of therapy a day, and our goal is a lot. Intense therapy with the goal of trying to get the patient home. So really, although we specialize in that neurological population, we will also take just a debility patient, post-surgical patients, orthopedic patients that maybe just need a little bit more rehab to be successful to go home. So rehab's kind of our niche. We do have a medical director that rounds with them daily to manage any medical needs. So they have to qualify to come to our unit. They have to have a rehab need as well as a medical management need to stay on our unit.
Excellent. So, and both LTAC and acute rehab unit are in-house here in St. Joseph, where swing bed is in Albany.
Correct.
And in Maryville.
Yes.
And I'd like to just comment about that. Mosaic is blessed. I say that we are blessed to have the breadth of post-acute, the scope and breadth of services, post-acute care services we have, and especially our swing beds. I don't know if some of you picked up on it. Lori said the patient really just stays in their acute bed. The bed is called a swing bed, but it is care where there's a physician there. There is nurse ratio is much shorter than it is in a nursing home.
Yes.
The government has, in their wisdom, called it swing bed. Some people confused it with skilled nursing facilities, but because the payment is somewhat similar, and also the qualifications, the medical necessity and the nursing ratios. But our Mosaic facilities, the level of care is, I call it acute hospital with rehab units.
Yeah, we're very much a transitional rehab unit. We really are. We focus on that. That's the pride and joy. We're able to be really flexible in swing bed. So I feel like we can meet patients where they are in both Maryville and Albany, which is oftentimes a challenge for nursing homes, long-term,
Yeah, they just don't have the staffing ratios we have in our swing bed programs.
So it sounds like there's a lot of similar patient profiles, maybe barring from the acute rehab unit, which is more an acute event that happens that leaves them debilitated or have a mobility issue, whether it be a stroke or a surgery. But it seems like with SNF or skilled nursing facility, swing beds, and LTAC, there's a lot of synergies, or at least a patient profile. So if I'm a patient, or if somebody's discharging me as a patient, what criteria would they use to say I should go to swing bed versus a LTAC? I think Lori, anybody really.
So here at Mosaic, I agree with Denise. We are blessed to have all of our post-acute care services. And we're also blessed that we all get along very well, and we have collaborative conversations every day. So we're working with the care managers and our physician teams to identify really where that appropriate place is. The different levels of care can be extremely confusing for patients and families, really confusing for us that work in it if it's not your specialty. So we call on the experts. So we have those conversations regularly, keeping the patient and family involved, as well as the whole clinical care team. But if I get a referral on a patient that's more appropriate for swing bed, I pick up the phone and I call Lori or I call Lindsay or Allie up in Maryville, and we have that conversation. And we're able to really identify the right place for that patient at the right time in their stay.
That's a good statement. It's about the right care at the right time.
Absolutely.
And there seems to be a lot of misconceptions out there in the community about if I'm going to a ICF or SNF, is that the same as going to an LTAC? And I think you touched on it a little bit, Denise. How do we manage to kind of tone down that misnomer or that rumor that it's a nursing facility if I'm going to a swing bed?
The focus that we have in our care management team we actually, marketing developed a nice virtual videotape of Albany to try to show the excellent care that the rehab care. And in our messaging, we're also focusing on the high level of rehab care in our swing beds compared to, it is a different level of care. They're just staffed so much better.
Right.
And you're in an acute setting where there is lab, there's x-ray, there's emergency department, and there's a physician. I mean,
They're going to round on you every 7 days.
Yeah.
I think a huge part of swing bed, it's great for patients who don't really have a plan of discharge yet or don't have a plan of care that's been individualized to them. They'll be rounded on twice a week by multidisciplinary teams that have the physician, the nurse, the therapies, the dietitian, social work, case management, and they all work really cohesively to help that patient partake in planning their own care. And what is the next step? That happens twice a week, every week with these patients.
And to see how their progress is going along.
Yes, yeah, they're really an integral part of that. So I feel like that's a huge difference from the nursing home, as well as having the physician available, at least every 7 days, but also as needed.
You mentioned therapies.
Yeah.
How many hours roughly of therapies do they get a week? Because I heard 3 hours in rehab a day.
Yes. And that is not a requirement for swing bed. Ideally, we would love to see a patient be able to manage an hour a day, but in swing bed, because we have in-house therapy, we have a lot more flexibility. I mentioned that in comparison to the nursing home. Ideally, we want to hit an hour a day with each patient, but we can come in and do 30 minutes, and if they're worn out, we can come back and do 30 minutes more later. So it's really just meeting that patient where they are and helping them gauge what they need to do to get back to where we are. I mean, they individualize those plans as well.
They're a big part of it.
Yeah, huge part of it.
Without the patient, the whole team just sort of deflates, doesn't it?
Huge part of it. Yeah, it's definitely centered around them.
So, Trish, I'm going to turn the attention to you for a second. You mentioned 3 hours of therapy a day.
Yep.
Are they on the treadmill for 3 hours a day?
No.
Are they doing jumping jacks? What does the 3 hours look like?
It's not like high intensity exercise like what you or I should be doing when we go to the gym.
Should definitely be doing.
But we incorporate it as also patient-centered care, and we incorporate all the functional tasks that they have to do into their day. So our goal is really to get them home. So whatever they need to be able to do to get home, we incorporate that into our therapy sessions, as well as building in the strengthening and the exercise. So if a patient has to do their own laundry and they have to go down the basement steps to be able to do their laundry independently, we're going to be focusing on strength, targeting the muscle groups that we need to get the stairs so that they can go up and down the stairs. And then also on the functional aspect, making sure that they can process and do what they need to do to sequence the steps to do the laundry tasks, making sure that they can carry the laundry basket and get it to where they need to safely. So all of those functional components. So we have a lot of fun on the acute rehab, but we try to really incorporate what the patients are going to be doing, because that's what's important to them is what they're going to have to do to go home. So it sounds like a lot when you hear 3 hours of therapy a day, but if it's everything that you do day to day, morning to night, when you go home, it's really not therapy. It's very purposeful.
It's re-engaging them back in their normal life before they have the event.
And then Tricia and Lori and Dana hand off to home health.
Right, let's touch on that.
Yes,
Wow,
we
you brought
haven't
it
talked
up.
about, yes, because they've had all this rehab, but then it's, as Tricia said, teach them how, but what does it really look like in their home? They prepare them to do the laundry or go down the stairs, but what does it look like in the home? And that's where our therapists, home health come in, and our nurses. But home health is, I have to say, Mosaic Home Health also, we're very blessed. We have a 5-star home health.
Give them a shout out because they deserve it.
They deserve it, and they sustain it. Quality and satisfaction, the best in the area. But our home health, the primary services in a home health are skilled nursing, that's a registered nurse, or a licensed practical nurse, and therapists. But then they're all services of an aide. The length of stay in a home health is generally 30 to 60 days.
Wow.
So it's intermittent. Again, it's the government's terminology that this is another lower level in the transition of care, that the patient doesn't need a nurse 7 days a week. Intermittently, they need a nurse, and intermittently, they need therapy. They don't need as intensive therapy as in the acute care settings or swing beds. So the next level is home health. And then we also have hospice. Mosaic has a wonderful hospice, which also has palliative care services within our inpatient and within our clinics. And hospice is the care of the patients that have decided,
They're on the tail end of the journey.
Yeah, I've lived my life. I've heard this conversation when I used to work in nursing homes. People get to the point where they're tired, they're wore out. They will tell you that. I'm tired, I'm wore out. But I want to live the last however long I'm going to live. So the goals of care conversations are very important. And the team that starts that can be in the home with home health, or it can be in the clinic, or it can be in our hospital. But a lot of those conversations around goals of care belong with our palliative care team that's in the hospital.
Well, it's everybody's responsibility to talk to
Yes.
the patient, because all these services that you guys are part of starts there. What are your actual goals for the patient? What does the patient itself, themselves want? So that's an interesting point, and actually a valuable point, because all these things are determined by the patients, all the things that we provide. And has it happened that the patient does not want anything beyond, the acute level? They say, I don't want to go to swing bed, I don't want to go to LTAC, and they have full autonomy with that, right?
Yeah. Another thing that our hospital supports, our health system supports, is our community palliative care. We call it serious illness management. Right. These are for individuals. There's no payment. There's no payer that pays for this. We have we run about 135 to 150 patients every single day. They're being seen by a nurse, social worker, and caregiver aides in the home. They're the people that are probably they have complex chronic disease, heart failure, COPD, but they need a lot of extra support to keep them so they don't have to go back to the emergency room of the hospital. So we provide resources. We identify resources and see them just to help them remain in the home. And I know Lori has a very robust program in Albany as well.
We do. We're very proud of her. She does a great job of managing all the complex patients and their conditions. Readmission rates have gone down significantly since she started her role. And that's what we're after. We want people to be successful in the home. We want them to have the care they need and then be successful. If they can't be successful, we haven't done our job. So,
You're absolutely right.
Yeah, she does a great job.
Interesting enough, we have 3 more services we haven't even talked about.
Which ones are those?
Post-acute. That's why you said we have a broad scope. Mosaic
It sounds
does.
like we have a decision tree from where the patient can go at the end of that. But I want to ask, how does that work if a patient goes from LTAC to swing? Has it ever happened they go from swing to rehab unit?
And vice versa.
Yeah, and vice versa.
Yes. Yeah. Oftentimes, we'll get them from LTAC because they've been very complex and chronic. We'll work with them, but then they're at a point or they're medically stable enough that they meet and need the more intense. So yeah, we work, it's a continuum.
Yeah.
We work in coordination and collaboration for those patients. We've gone different ways in each area. So yeah, might start in acute rehab and come to us, or come to LTAC and vice versa.
As long as where the needs are.
Yes, absolutely.
Excellent. And Tricia, what's the average length of stay for the rehab unit, you would say?
Yeah, it's very variable. We try and do it patient-centered. There is some payer that plays and factor into that, but we do advocate for our patients to get the longest length of stay that we can. It's really determined by their diagnosis code. So when they come in, we really try and capture every qualifying diagnosis that would get them a longer length of stay to give them the full benefit of their rehab.
Excellent. So it's kind of like a game within a game.
A little bit of a puzzle.
All great stuff. So it seems like in some of these patients, the payers or CMS, Medicare, Medicaid determine where the patient might end up, which is sort of a rate limiting step. Lori, can you touch on that, how some patients qualify and some patients don't?
Oh, absolutely. Different programs have different requirements, and different payers require different qualifiers. So that's all taken into account as you move through the system and the continuum. What's going to be the best fit for the patient? Where can we be the most effective in their care? Some programs do not cover specific things, as swing bed is not covered by Medicaid, but it is covered by Medicare and Medicare Advantage plans. And most commercial commercial insurances have some sort of post-acute coverage. It's just very much case by case. But I feel like case management gets really involved in that and can explain that to the patients. That's kind of at the front end. I think Mosaic is really focused on visiting with patients about discharge from day one. Like, what are your goals? What are your plans? And we start looking at that and what is the best fit.
Right. So if I'm a Medicaid patient, unfortunately, I won't be able to come to Albany.
Correct.
But I may qualify for LTAC?
Yes.
Absolutely.
Does Medicaid
Yes.
cover ARU? So most of them, it seems, Medicaid being the outlier, it seems like, in some possibly commercial payers,
Sure.
most of these services are covered.
Yes.
And if they're not, we figure out a way to find
Yes.
the best fit for you in the meantime.
We do.
So we touched a lot of that post-acute, and Denise, you mentioned there's some multiple services outside of LTAC and swing beds and acute rehab units that we provide for our patients.
The community nurse call line.
What's that?
Most everybody in the community knows that, but it's a 24-hour nurse call line that does a lot of triaging. I hear story after story of things that, and accolades from patients where they called in to the community health nurse, got some triaging, and they sent them either to the emergency department or give them some advice over the phone based on triage criteria, best practice, and the patient has improved or gone to the clinics or wherever.
It prevents them to come to the ER if
Yes.
we can help them over the
Yes,
phone.
Yes, and they also play a key role. If there's no post-acute care that patient's discharged to, they will call within 24 to 48 hours the discharges that didn't have a handoff to a post-acute. So
Gotcha.
they're calling, a nurse is calling the patient within 24 to 40 hours, discharge.
And that's a great way to follow through with the intention of after the discharge. The care doesn't stop once the discharge orders are in.
That's when they pick up, there's a little confusion with their medications, or they're not quite sure about when was my doctor's appointment, because there's a lot going on. You get discharged in 4 or 5 days. It's
A lot of people come into the room, a lot of conversations are happening. It's hard for them to keep track sometimes of all the things that are happening.
Yes.
I want to touch on one thing. So it sounds like all the patients who are admitted have all these possibilities. Do you all take patients from the community directly?
We do on the acute rehab unit.
Oh, is that so? How so?
Yeah. So like if that patient, like Denise was referring, calls into the nurse line, they're not doing well at home, something's not going well, and maybe they're failing at home. If they qualify and meet our criteria, we can bring them back into our setting for rehab to make them hopefully return home and be successful.
So how does that work? They just call the acute rehab
We
unit?
have two clinical liaisons who you might think of as like admissions coordinators. So we have one that does our internal population here at the hospital, and then we have one that would do our external market. So we take patients from not only from within Mosaic, but from external hospitals as well that qualify for rehab. We have 5 admission criteria, so they're kind of an expert in looking at that to determine if a patient meets that criteria. And then that patient referral comes to me as well as to our medical director to make sure that the patient meets and that we can approve them. And then we coordinate with their physicians, their primary care doctor, to get them back to us on the hospital side and get them the rehab they need so that they can go back home and be successful. Trial number 2.
That's excellent. So they don't need to be admitted to come to the rehab unit, but they definitely need to be admitted. Not for swing bed?
Not necessarily.
All right.
If they've had 3 midnights in the last 30 days and they've failed therapy or failed at home, they can come and be readmitted to the hospital. Sure, we'll put them back in swing bed.
Okay. So it's even after they've left the swing bed, and if they're not doing well, they can
They
coordinate
could, or if they were never in swing bed, if they were in another program and they failed the therapy at home and they need more care, that is always something we can look at. It's that qualifying 3 midnight stay rule that we have to meet, and then medical necessity. But we could.
And the PCP makes a referral.
That's correct.
Excellent. So, see, I'm learning, and I've been doing this thing for 15
Yeah.
years, Excellent. Anything else, Denise, you want to touch on in part of our community outreach outside of the nurse line that we offer?
We call it the Care at Home program, and that program is physician and nurse practitioners that follow patients after they're discharged from the hospital. They may follow them into the home, or they may follow them into the nursing home, where they could be rounding on the skilled nursing patients, or the if that's their home, we call them intermediate care, but in the nursing home. So we have 3 APRNs that do that, and we cover, I think it's 8 or 9 nursing homes now that we are actually in the nursing home. So the hospitals know they can hand off. The hospitals can discharge, or the primary care can discharge that patient into one of our post-acutes, or into, if the patient came from let's say, living community. They'll discharge them back there.
So it sounds like there's a lot of options for not just for the physicians and the APPs that are taking care of our patients, but also for the patients themselves when it comes to coming to discharge.
Yeah.
And I'm glad you all four are leading the charge, because it can be confusing. It can be quite, for them it's just one admission, but for us, we know how this could play out in different ways for them. Dana, you said LTAC sees those chronic complex patients, and you mentioned some really high numbers of length of stay. Anything from the community that you take patients directly to LTAC as well, or?
Yes, we can directly admit. So we do directly admit from some of our clinics, and we can actually direct admit from the emergency department. So if a patient has spent a lot of time in and out of a hospital, Lori kind of mentioned failing outpatient. That is one thing. We try to get patients to as close to home as possible, but sometimes patients can't tolerate that level of care. So they do need to backpedal a little bit to more of an acute level of care, or even swing bed or ARU. And we are able to bring them back into the hospital setting. Now, sometimes we've talked a little bit about payer. That may be payer-driven on direct admitting from out in the community. We like the ARU. We also admit from external hospitals, so Kansas City, Omaha, Lincoln, Cameron, Atchison, so from outlying facilities as well. But several of the payers require prior authorization. So commercial payers, Medicare Advantage, Missouri Medicaid, other state Medicaids all require prior authorization, meaning that our care management team has to send in a portfolio of really the clinical case of that patient, really showing the criteria being met for any of our levels of care. And then they have the ability to either say, yes, we will authorize that stay, or no, we won't. And then we go from there. So some of our payers, we're not able to directly admit from those external facilities. We do require an inpatient stay where we can document a good treatment plan for those payers before they would authorize that.
Oh, I love prior authorization.
Yes.
Everybody, yes.
If you can't pick up the sarcasm on the camera, it is there. It is the bane of my existence, because you have to justify the need of the care, and you're sometimes talking to people on the phone who have no idea what they're doing, who have eyes on the patient. So all the physicians and APPs listening out there, document well. That really does make a huge difference from the care management side. I'm going to turn the question a little bit here. What can physicians or APPs who are taking care of patients do differently or do more of to help these services be used more often? This is kind of a free-for-all if anybody has any ideas or they think they're...
I think engage and educate themselves on what's available. You know, we have so many services out there, and I just think acquainting yourself with all of us. And if you don't know the answer, we're happy to come in and talk about our area.
Yeah.
I agree, and I even think come visit the areas. You know, actually being physically in this space is very eye-opening and very enlightening, and it's very engaging. All of our areas are open to visits as well, so even from our, clinical physician teams and APPs, whoever may be driving that decision or helping with that decision with the patients, feel free to come on over and, take a look at the types of patients that we take care of, because I think once you do educate yourself, you're able to educate the patient and family even clearer.
Even take you on home visits.
Yeah.
Anytime, Dr. Mohan.
I would love to. I don't know if the patients would, but I would definitely love to. Tricia, what do you think?
I agree with kind of the points that Lori and Dana made. I think just having the physician to really understand what our niche is and what we offer on our unit to help that patient decide what is the best fit for them. And then also, as we've said, payer does play a factor in pre-auth. So if they don't qualify for one, what's the backup? What can we qualify them for that would also meet their needs?
Yeah. If you can't get into Harvard, you got to have a backup school.
Yeah.
That's what I always like to tell my patients. Reach out, learn more about the services provided, and know what's out there, because you may qualify for them. And as our patient population is aging in Northwest Missouri in general, all these services are much more essential than they were in the past, because time does not go backwards, unfortunately, as much as we want it to. Well, there you have it, folks. We had a lovely discussion with Denise, Tricia, Dana, and Lori, and I thank you very much for joining us. All the services that we provide from Mosaic, whether it be acute rehab, LTAC, swing bed, or the multitude of care at home SIM program that you mentioned, Denise, are just a way to continue our great care. Medical care does not stop when the discharge order is placed. In fact, I believe it starts there. And all these services is a big part of it. And I thank you all for doing the great work. Thank you, and I'll see you next time.